So this is a card I got when I was a medical student. I treated a patient with alcohol withdrawal, and I was nicer. Is this not working? No, it's not working. Sorry. So I was a nicer guy back then, so I got this very sweet card. But if you look carefully, you can see this patient is still having a tremor because we gave this guy a ton of Ativan. We had him on an Ativan drip. We sent him home with a bottle of chlordiazepine oxide. And even after being in the ICU and a complete hospital stay, this patient still has a tremor. So today I'm a burned out ICU attending. I'm not as nice a guy. My patients still give me cards, but they don't tremor. So this is the outline. A quick word on neurotransmitters. For a long time, I used to think that alcohol withdrawal was simply a deficiency of GABA receptors. And that's often the way it's taught. But I've realized that that's really not the case. Chronic alcoholism really fucks up your brain. And it causes changes in a lot of different receptor subtypes, including GABA receptors, glutamate receptors, all sorts of different changes. So a standard benzodiazepine is only going to treat part of the solution. Phenobarbital has a more complex mechanism of action, so it's going to actually hit the glutamate system, it's going to have some sodium channel effects, it's going to have some GABA receptors. It's more of a broad spectrum agent. It's kind of like the Zosyn of sedative hypnotics. A brief history of alcohol withdrawal in Denmark. Couldn't resist this slide. This is worth reading for a minute. So back in Denmark, for decades, they used to treat patients with barbital, which was a precursor of phenobarbital. This was way before critical care existed. They didn't have ventilators. These guys would come in and they would just give them oral barbital until they fell asleep. And then they'd wake up and they'd be fine. I believe that this is probably the best description of how to treat alcohol withdrawal in the English language literature, including my blogs. Unfortunately, pharma came along and in the 1970s, 1980s, pushed benzodiazepines really, really hard. Ativan here is going to fix all of our ills. And eventually, people switched from using barbiturates to benzodiazepines. In my opinion, that was a mistake, and we're slowly realizing that and slowly going back to our initial model in the 1900s. And unlike this advertisement saying, there are few certainties in life, I find Ativan to be a relatively uncertain medication. Sometimes you give it to patients, they get super somnolent. Sometimes you give it to patients, they can have a paradoxical reaction and get worse. So you're kind of rolling the dice. So a couple advantages of phenobarbital. I've been trying to push this for years. Luckily, as Megan was discussing, there was a drug shortage of benzodiazepines, which has kind of facilitated some more interest in phenobarbital. So there's a little bit more traction for this currently. But for those of you who are still using benzodiazepines, these are the reasons that I think phenobarbital is better. So first of all, there's less cross-tolerance between alcohol and phenobarbital compared to alcohol and a benzodiazepine. So I think we've all seen patients with alcohol withdrawal who just chew up benzodiazepines and are refractory to super, super high doses. That doesn't seem to occur with phenobarbital. The dose range that you need for phenobarbital is a lot narrower. So for phenobarbital, you're going to end up giving patients somewhere between 10 mg per kg and about 20 mg per kg. Whereas for benzodiazepine, one patient might need 20 milligrams of Valium, the next patient is going to need 500 milligrams of Valium. So there's a huge point spread, and it's harder to figure out how much drug the patient needs. Phenobarbital is less prone to failure. So there is a subset of patients who have refractory alcohol withdrawal, and they do not respond to benzodiazepines. I think most of us have probably seen this. I've encountered some people who deny that this exists, but I truly believe that this is a thing. And probably it relates to the fact that benzodiazepines are only treating part of the neurotransmitter problem that's going on with these patients. So their glutamate systems are still really overactive. There's a lot of other stuff going on in their brain that's simply not being touched by the benzodiazepines. You can give these folks hundreds of milligrams of Valium, they're going to laugh at you. Phenobarbital is the hammer of neurotherapeutics. There is no positive symptom that cannot be stopped by phenobarbital. It can stop everything. It is impossible to have a patient who won't respond to phenobarbital. At least I haven't found it, and it doesn't seem to be reported in the literature. Less delirium. So I think we've all probably experienced paradoxical reactions with benzodiazepines. So this is the patient who's super nice, really sweet. You need to do a procedure on them, give them some benzodiazepines, and they turn into a raving lunatic. And it doesn't happen a lot, but it is a problem. And sometimes I do think, and there's actually an increased rate of paradoxical reactions in patients with alcoholism. And I do think that this sometimes happens. Folks come into the ED with alcohol withdrawal, we give them some benzos, and we actually cause kind of a paradoxical reaction, and they get worse. It's one of my favorite slides, the classic ICU slide relating lorazepam dose to delirium. Basically, if you give 20 milligrams of lorazepam, you're going to ablate that patient's ability to think. And this causes a huge problem with alcohol withdrawal that often occurs day 2 to 3 to 4 after admission, where patients come in, they get a bunch of benzos, they're doing a little bit better, but they're still confused. They have this lingering confusion. And this leads to a lot of challenge, because how do you treat these patients? If their confusion is due to alcohol withdrawal, then they need more benzo. If their confusion is due to benzotoxicity, then they obviously don't need more benzo. This was one of my favorite studies. They looked at patients day 3 to 4 post-admission and actually gave them flumazenil, which I would not recommend. But they were toxicologists, they were very brave. They gave them flumazenil and the patients improved. And what that demonstrates is that a lot of these folks who come in with alcohol withdrawal, we give them benzos, they get confusion for several days. A lot of that confusion is our fault. We're giving them benzos, we're giving them benzo-induced delirium. And my experience with phenobarb has been when you give folks phenobarb, they tend to kind of maintain a more normal sensation, and I think that there's probably less delirium going on. So benzo, you're kind of rolling the dice. Some patients get better, some patients are refractory, some patients go crazy, some patients have paradoxical agitation. Increased efficacy for seizure. There's not a ton of evidence for this. Both benzos and barbiturates are pretty good for seizures, although my bias is still that barbiturates are more powerful for seizures. And there's a little bit of evidence for this. In general, if you look at the status epilepticus literature and the neurology literature, I think barbiturates are generally believed to be more powerful for seizure. So if you're admitting someone with alcohol withdrawal and you want to be able to go to sleep and you don't want to get called at 3 in the morning because they're seizing, if you give them a nice loading dose of phenobarbital, less likely to get woken up. Reduced requirement for redosing. So this is typically a problem with lorazepam, where somebody comes into the emergency department, you treat them with lorazepam, they get a whole lot better, life is beautiful, you admit them to the floor, and then 10 hours later, all of the lorazepam wears off and they go completely crazy again. And you're kind of all the way back to step 1. Phenobarbital has a huge half-life. So once you can titrate up the dose and achieve symptomatic control, these patients might need a little bit more, but they're not going to slip all the way back into very severe withdrawal symptoms. And finally, pharmacological simplicity. We've all been there. These are great calls, to get in the ICU. Yeah, I gave them, some of this, and then we put in some clonidine, and then we threw in some Haldol, and we added some fentanyl, and this is torture for me, okay? So the patient's not doing poorly. Is that because they had an extrapyramidal effect from the Haldol? Is that because they had some sort of a paradoxical reaction from the lorazepam? I don't know. I have no idea what's going on with this patient. In the pharmacokinetics and the interactions of all these drugs are just, this is torture. So phenobarbital cleans this up. You're basically going to choose one drug. And the pharmacokinetics of this drug are extremely beautiful. So this has been worked out for decades. So before we had Keppra and Vimpat and all that stuff, for decades, phenobarb was the go-to drug for status epilepticus. And neurologists invested tons of energy into figuring out the pharmacokinetics of this drug. It's actually very simple and pretty straightforward. if you look at the cumulative dose of phenobarbital, that's basically going to form a line with the serum level of phenobarbital. So all you need to do is keep track of how much phenobarb the patient has received. Given the 72-hour half-life, the phenobarb is going to build up in the patient's body. So it doesn't matter if a couple hours isn't going to make a difference. You're basically just adding on to the patient's phenobarb dose. And this makes it very simple. So if someone calls me up and says, I have this patient with alcohol withdrawal, I've given them 12 mg per kg of phenobarb, I know exactly what's going on with that patient. I know what their serum drug level is. I have a good sense of where they are. That said, there are a couple disclaimers. So when not to use phenobarb. So I don't want you all to go out and just start using phenobarb on everything. Come in with a stub toe. We're going to give you 10 mg per kg of phenobarb. You're going to rate this ED experience really highly. So phenobarb is a long-term commitment to this drug. So when you give phenobarb, that patient is going to have phenobarb on board for 3, 4, 5, 6 days. So you want to be a little careful about giving this. If you give this, to the wrong patient, you can't really take it back. So I like to use this for patients who I really feel confident that this is an alcohol withdrawal. In a complicated situation, where I don't know, is this alcohol withdrawal, is this ICU psychosis, is this some other intoxication, I don't really know what's going on. Giving a huge slug of phenobarb may not be the right thing to do, because if it's wrong, you're kind of stuck with it. So far, I've never had a situation, I've been really afraid that eventually someone would give phenobarb to some patient, and they would go into a coma and be intubated for like 7 days, and everyone would be like, Farkas, this guy's intubated for a week, and there'd be some M&M. So far, that's never happened. And I'm pleased to say that, so far, we haven't had phenobarb kind of inducing a coma, but this is worth considering and kind of being aware of. There is a risk of interaction with benzodiazepines. So both phenobarbital and benzodiazepines interact with the GABA receptor, and they can do so synergistically. So phenobarb basically stimulates the receptor directly, and then benzos modulate it. So the bottom line is, if you start adding these drugs together, they can work synergistically, and you can get into a little bit of trouble. The patient where I got the closest to having to intubate a patient due to phenobarb was a guy with alcohol withdrawal and a personality disorder. And I said before that barbiturates will stop any neurologic symptom, and that's true. But you should not use barbiturates to treat a personality disorder. And that said, seriously, when you're using this drug, you have to be careful, especially with the CWAS score and so on. You have to make sure that you're truly, titrating to alcohol withdrawal and not something else. Not like, the nurses are angry at this guy, or he's, trying to, run around the ICU because he's just, has a personality problem or a psychiatric problem. So we had a guy in the ICU with a combination of alcohol withdrawal and some personality problems, who ended up getting about 15 or 18 mg per kg of phenobarb. He was still kind of out of control. I think more so because of his psychiatric issues than his alcoholism. And there was a lot of, commotion, and someone slammed in like 20 or 40 milligrams of Valium, and he was in a coma for like 8 or 10 hours. He didn't require intubation, but he came close. So I think the bottom line here is, number one, make sure that you're treating alcohol withdrawal. And number two, be careful if you have a patient who's received 15 or 20 mg per kg of phenobarb. You can give them benzos, but those benzos are going to be more powerful than they would be otherwise, and just be careful with that combination. It is possible to OD on phenobarb. So a couple years ago, I put out this kind of protocol on the blog, and we used this, and it worked well. We ran into one problem, which is that occasionally folks would end, so the way this works is patients come in, if they don't have any other drugs on board, if they just walk in off the street with alcohol withdrawal, then you can start with a 10 mg per kg phenobarb load. And that is extremely safe based on the pharmacokinetics of phenobarbital. That's going to get them a drug level of about 9 or 10, which is totally safe. I could give you all 10 mg per kg phenobarb right now, and you could probably go out and ski. If the patient has had a bunch of benzos, you might not want to do that though. So basically this protocol starts off, has the patient been loaded with other stuff? If this is a totally clean patient, you can give them the 10 mg per kg of phenobarb. If it's a more complex situation, if they have benzos or other stuff on board, then you can give titrated doses of phenobarb. And the way this is written, you can just continue with the titrated PRN doses of phenobarb indefinitely. And you can also do oral phenobarb if you're trying to send them to a medicine floor and the medicine team is like terrified about intravenous phenobarb. You can use that as well. It's a lot cheaper. There are some price issues with intravenous phenobarb. And this worked very well. The only problem that we ran into with this protocol was that some patients would end up in this third box and they would keep on getting PRN doses of phenobarb. And once again, you need to use phenobarb to treat alcohol withdrawal. So some patients were getting this just, patients would actually feign withdrawal symptoms so they could get the phenobarb. Some patients like phenobarb. Other patients might develop delirium due to some other cause, ICU psychosis, so on and so forth. And they would get a lot of phenobarb. And we did get a couple of patients who received more phenobarb than they needed. It actually proved to us how safe phenobarb is. So we had some patients who ran up their phenobarb levels pretty high, and they were fine. But what we realized is that it is possible to OD folks on phenobarb. You can get a little bit of confusion and stuff like that. So what you need to do is keep track of your doses. And once you start hitting 20 or 30 mg per kg of phenobarb, that's when you should really start, saying, is this really alcohol withdrawal? It's probably, it's time to start cutting back on the phenobarbital. So where's the evidence for this? There's not a ton of evidence. This is the closest I could come to a randomized controlled trial of benzos versus barbiturates. This was in the 1970s. And the problem is that historically, we transitioned from barbiturates to benzos before evidence-based medicine existed. So there's no good studies back then. This is the closest that I could find, and it actually suggested a benefit for barbiturates. Of course, Pharma won, and the barbiturates ended up going away. But there's probably some evidence there that it might be good. This was a more recent randomized controlled trial by Rosanson. Basically, they looked at giving folks 10 mg per kg of phenobarb, just kind of walking in the door, and they showed reduced ICU admission and a lot of other good things here. So if you're admitting a patient with alcohol withdrawal, and if you can hit them with 10 mg per kg of phenobarb right up front, you're going to get their phenobarb level up to about 10. That's going to have a lot of beneficial effects for them. Even if the floor team decides to go with lorazepam or Valium, that's still beneficial. And this was a slide that I stole from Kyle's Twitter feed. The folks at Harvard at Beth Israel are doing a study, kind of a before-after, where they're looking at phenobarb in their ICU. This has only been released in abstract form. Hopefully the full study will be published soon. I'll be able to blog about it. But the results available in abstract form are pretty optimistic. So it's not just this UVM. A lot of other centers, UMass is doing it. Nuts and bolts how to actually do this. So this is actually the most recent algorithm that we've come up with for dosing this, which is very similar to the prior algorithm. You essentially look at the patient coming in. If they don't have any drug on board, you can start with the 10 mg per kg load. Otherwise, you can dose incrementally. And the only addition that we've had to this is that you should keep track of your total dose. And once you hit 20 mg per kg, really think about, is this really alcohol withdrawal? Is there something else going on? And especially, I definitely wouldn't give any more than 30 mg per kg. At that point, you could probably say, we've treated whatever alcohol withdrawal exists. Whatever is left here is something else. And you can also check drug levels if things get really confusing, although you typically don't need to do that because of the linear relationship between the dose and the drug level. So that's it. There's a lot more stuff here on my blog. And you can feel free if you have references there, evidence, and also if you come up with random questions, you can always put them on the blog and I'll try to answer them. Questions? Yeah?
How about adding Haldol to those?
Yeah, so great question. Where does Haldol fit in the mix here? So Haldol typically has been frowned upon up front for alcohol withdrawal because it maybe can increase seizure threshold and it's not an anti-epileptic agent. I think the place for Haldol is that patient where you admit them, you give them 20 mg per kg of phenobarb, they're still kind of delirious or confused. After 20 mg per kg of phenobarb, I'd say I've treated this patient's withdrawal pretty well. They have a good dose of anti-epileptic on board. That's the time I think when you could switch to a Haldol. Because you've kind of you've used the phenobarb to treat the alcohol withdrawal. Now you're basically using the Haldol to treat some like residual delirium. Yeah.
Josh, what does the literature say about, sometimes we don't know if we're going to send these people home, like they come in and so if we send them home and they go drink and we gave them a 10 mg per kg phenobarb load, how risky is that?
That's a great question. There was one RCT that looked at giving folks phenobarb and sending them home. They used less than 10 mg per kg. I think it was 360 mg. So there's a little evidence basis out there saying if you give someone phenobarb and send them home, they're going to do okay. I don't think that there's evidence base for using the 10 mg per kg. I don't think it's unreasonable to do. I would absolutely document though and warn them that if they drink, they may become more stuporous than they would otherwise become. Mm-hmm. And you could imagine some sort of pathway where like folks come into the ED, get 10 mg per kg of phenobarb, and then go to like some sort of like dry out facility.
Definitely.
Not the ICU. Yeah?
Does your professional drinker with his alcohol on the way down, do you still keep on the way down, or do they have to be alcohol free?
Great question. So the question is, as someone comes in with a high alcohol level and it starts drifting down, can you give phenobarb? If someone's...
They start withdrawing 200, but probably...
Yeah. There's no evidence specifically on this. I would say if a patient is displaying alcohol withdrawal, I think you could give them phenobarb. Another situation where I will use this is if someone who's a professional drinker comes in for an MI or something and they give you a history that they're drinking a liter of vodka a day, you know that patient's going to withdraw. I'll give those folks 10 mg per kg of phenobarb just up front in the evening to help them go to sleep. So I don't have a great answer for you, but I think if they're showing signs and symptoms of withdrawal, I think that'd be reasonable. Maybe not the whole 10 mg per kg, maybe just wait in with some PRN doses. Yeah?
How about any role for phenobarb in the functional alcoholic in the outpatient setting who wants to stop?
Ooh. Yeah, I think
How do you load them up?
You know, I don't know, I don't work in the outpatient world, but I think once again you could give them somewhere between 400 or 10 mg per kg of phenobarb with instructions to not drink and warnings. I think that would be reasonable. And one advantage of phenobarb compared to chlordiazepoxide is we used to send these folks home with bottles of chlordiazepoxide, which I think is really sketchy. You're giving someone with a substance abuse disorder a huge bottle of benzos. One nice thing with phenobarb is they go home with the drug in their system, but they're not going to misuse it.
That's true. I just don't find people sleep liver and not.
Yeah.
Have you ever seen that before?
We kind of pared back on chlordiazepoxide, so I've never seen that.
Thank you.
Thank you.
Good morning. Thank you for staying. I do a lot of simulation back at Boston Medical Center, and if you look at the sort of learning literature, there's very good evidence that you're going to take away and remember absolutely nothing from the next 20 minutes. So we'll do our best to go through. So I thought this would be really easy to prepare for, and it turns out it's kind of hard because, what are your pearls of literature? So here are my objectives, and I hope you can at least take home a couple of things. First is look at papers from the last year and a half, make sure they're current. Second is make sure there's some sort of a point that the paper makes that you can actually apply to your practice. I think some of these you're going to look at and say, oh, I've been doing this for years. That's great. Now you know there's a paper to back you up because I like to practice evidence-based medicine. Okay, starting off with this study. Neonates with febrile UTI, how often is there meningitis? So we always have these decision rules and these algorithms, and you have some that's less than a month old with fever, and there's this huge sepsis workup. So people are trying to tease out how often you see different disease processes together. So here's our question. If you have a neonate with a UTI and you know it's a UTI, how often are you going to see a positive LP? They had over 200 kids. They were all less than 30 days. It's a great population, and they all have confirmed acquired UTI. So what did you need to have? You'd have a temp of 100.4 either at home, as reported, or in the ED. And then the nice part is your urine had to be a clean collection. So either suprapubic aspiration or straight cap. Those are the only two that were accepted. And of course, they had to also done an LP, and then we just compare the groups. All right, so not surprising. I do mostly adult, occasionally moonlight, and when I see a chart that says, 3-week-old with fever, I get very upset, and I walk into the room, and the kid's gurgling and smiling, and I'm no longer upset. And this is kind of what you see, 80% well-appearing, so, that's great. Most of them are male, and E. coli grows up in the urine the vast majority of the time. I don't think there are any surprises there. Here are your results. 0 children met the definition of acute bacterial meningitis. That's kind of a nice number. Now, there were 2 LPs that were bloody and were possibly positive, but going back through the charts, the doc said these kids looked very well. It wasn't even on their radar as a diagnosis. Okay? So, take home, I like take your next shifts better. I'll change that for next time. But so, in the setting of a true UTI, you do not see bacterial meningitis. It probably doesn't exist. So I wouldn't say that you have a sick kid, you're not going to do this when you do straight cap and it's clearly positive, but I think it's nice to know, especially if the families refuse or for whatever reason you're not going to do an LP. This is nice information to have. Questions? Okay, next. This is a quickie, but I get this from my residents all the time. Is it safe to inject live epi into sort of these end processes? Fingers, toes, ears, nose, tip of penis. Yes, no, people do it. How many people here will use live epi for digital block? Got some hands are up. It's totally safe. It's been shown in literature many, many times it's safe. The best study I saw, they injected a finger, it went down for almost 2 hours. That might make you a little, take a little pause, but the circulation came back. No one ever had any complications. I usually tell my residents to use bupivacaine, but they keep getting pulled away to other things, and they come back, and the lido's worn off, and the patients are really pissed they have to get an injection again. Lidothepy is okay. This is not a study. I just want to show you how okay it's considered. This is the Journal of the American Academy of Dermatology, and it's guidelines for the use of local anesthesia in office-based dermatologic surgery. All right? I think if you're in a dermatologist's office and they're about to inject the tip of your penis, you may want to make sure it actually needs to be done. But apart from that, I think this is good information. And they say use caution. I would recommend you use caution. I'm not doing that. All right, switching gears. No questions about that? I take it? Right, this is really good. I like the study. Those of you who have been following the BNP literature, you should already know that BNP is actually not useful really at all in CHF and trying to discern pulmonary versus cardiac shortness of breath. Of course, if you have a BNP of 4,000 or a BNP of 0, yes, it's helpful, but it doesn't really contribute to anything better than your own physical exam. So the question was, we always eliminate people who are older than 80. So these people looked at what happens the older. These guys really want to know. They come in, they're short of breath, they're hypoxic. Is it cardiac? Is it pulmonary? We don't know. Here's your study question. Can the BNP be used to discriminate cardiac and respiratory dyspnea in old people? All right, these are old people. Okay, this is not 65-year-olds from like all these decision things from 20 years ago. These people are almost 90 years old. All right. They present with either shortness of breath or hypoxia. There's 400 of them. It's a cardiology study. All right, so the cardiologist is looking at these patients. They're asked to determine pulmonary, cardiac, but they're having the BNP withheld. I think that a cardiologist workup is probably reasonable, and we can use that as a comparison to what we do. Okay, and this is, I can't remember, I think it's in England, so there's a European society that says you have to diagnose CHF by using these criteria, and one of them is get an echo within 72 hours. That's why the echo is up there. Okay, so 2 out of 3 of your 90-year-olds are shortness of breath. It's cardiac. 1 out of 3 is respiratory. And yes, the BNP is higher. So the average BNP in the cardiac people was in the mid-3s, 300s I mean. Respiratory was around 150 to 170. But here's the interesting part, and the reason why I included this. The BNP did not improve the discrimination between cardiac and respiratory etiologies. What does that mean? It means that you got your patient with a short breath, you did your eval, you decided it was cardiac, and then you looked at the BNP. It's not going to help you because you're good enough as a clinician to know that without a lab value. So my take home for this is don't get a BNP if you're trying to discern between cardiac and non-cardiac styles. Questions about that? Awesome. Good. Does anyone know who this is? It's Dionysus, the god of the grape. So I always go with some kind of a digression. A number of years ago, it was the Templars. You can be happy that I'm no longer those guys. And then I started reading the Gospels, and for a while I was like, Jesus this, Jesus that. And I was just like, stop talking about Jesus. And just full disclosure, I'm Jewish and an atheist, so it wasn't obvious I'd be talking about Jesus. So my new thing is mythology and how the myths sort of were incorporated in religions. This is really interesting. So imagine the apostles starting off the Holy Land. They're sort of walking sort of northwest through what's now Lebanon and Turkey and Greece. They're going to be exposed to all these kind of myths and things. This guy, apart from getting super hammered and having orgies, which has got nothing to do with why he was a god of grape, there's 2 other things that are really interesting. He died and was resurrected. So there's a resurrection myth in there. And the second thing that was interesting is there's a very religious component, because when you get drunk, you get disinhibited. And they start to sort of realize there's sort of a subconscious, and there's the possibility and the idea of God being inside every person as opposed to being outside. So the Greeks, the gods were always outside. Also the early Judaism, you had to go to the temple to worship God, and then sort of became, God could be everywhere. So you could have, a synagogue or a temple or something, and God would be there and with you. So I thought that was kind of cool. All right. Yoga for chronic back pain. Do not do this at home unless you are already doing yoga. Is it better than, actually this is a non-inferiority trial. I like this because all they do is just compare and say, is it as good as? Doesn't have to be better, just as good as. So I'm sure you're seeing this in the lay press, people talking about it. This is a randomized trial. Basically you got yoga once a week for 3 months. Or you got physical therapy once a week for 3 months, or you got some self-help books and said, read this stuff and do whatever you want, which is a lot of what we usually do, right? So the evaluation, they looked at things you'd want them to look at, whether their back pain improved, whether their activity was limited or got better, did they use a lot of pain meds, were they satisfied, and what was their quality of life. So results. Not surprisingly, yoga and PT were similar, so it's non-inferior. So basically what it's saying is, yes, with back pain, I think the reason why I brought this in is because we all see a lot of back pain. And I feel like we do a really bad job with it, because I'm giving them ibuprofen, maybe a Flexeril, maybe not. I'm spending a lot of time telling them why I'm not giving them oxycodone. It's just kind of, and then they'll see you later, do something, stretch, and we'll see you. Yoga is actually really good, and the thing about this is once a week. So for those of you keep in shape, doing something once a week doesn't really do a heck of a lot. The fact that it does anything, I think, is really kind of cool. And I think that's more something people can do at home once if they continue and they follow these people, the PT and the yoga, and a year later, people who were continuing to do yoga still had positive results. So they felt better, their backs were better. So I think it's important to know. The problem is. And they need less pain meds as well, compared to Sealy, which is nice. It's not covered by insurance, so depending on your population, that could be an issue. I do think it's probably a lot cheaper than physical therapy, and it's as good. So I thought that was an interesting study. Might be something insurance companies might look into. because that's not a lot of money to buy a few yoga lessons. Questions on that?
There's a broad array of different types of yoga. Did they specify what type or the activity?
So the question is, did they specify what type of yoga? I'm sure they did. I can't remember because I don't do yoga, so I probably just glossed right over that. That's a good question. Yes?
Did I read that it wasn't superior to education at all?
You did read that, yes.
So education's just good.
Well, they needed fewer pain meds, and then the yoga group a year out was still feeling better. So those people who stayed in shape. But yes, you're right. So there's not a huge difference in any of these groups, but there is a benefit. And I don't know, they must have looked at their controls a year out and found that wasn't the case. Okay, spontaneous pneumothorax. I like this one. How many people you get a spontaneous pneumo will do a needle aspiration watching? Nobody does needle aspiration. Okay, that's really interesting because the literature says that this is the best way to do it, and this is just another study that confirms it. So let's go through this. Easy study question, who does better in spontaneous pneumo? Patients who get aspirated or patients who get chest tubes? Now, when they say chest tube, if we do it in our place, we'll be putting in a pigtail. So it's small, but it's still a chest tube nonetheless. 127 adults in 3 hospitals in Norway. I believe all 127 of those adults were offered citizenship in the U.S. by the Trump administration. And you had to have a primary or a secondary spontaneous pneumothorax. What's the difference between primary and secondary?
Healthy lungs
That's it, yeah. Healthy lungs are not healthy. So your primary is your sort of tall, thin, smoking 20-something-year-old male with no diagnosed pulmonary disease. Secondary is all the other people who have some sort of underlying pulmonary disorder. They're more in their 40s and 60s, and they usually get a lot sicker when things happen to them. All right, simple. Randomized to needle aspiration or chest tube. So what do you do with needle aspiration? The problem is those things reaccumulate. So you watch them for 6 hours, and the needle aspiration group was allowed to be aspirated a second time in 6 hours if the air reaccumulated. Here's your setup. It's pretty simple. This is not the catheter you're going to use. How many of you guys have done needle decompression before? Okay, I don't know if you know, but I mean, even that 2.5 inch, sometimes you drill that into someone who's super thin, and you go, where did this thing go? I don't hear in the air, I don't know where, so you hub it, and you think there's probably this much chest wall, and there's this much catheter, and you still don't get the air back. And it's one of life's mysteries. But if you get it in, you connect it to the stopcock, then you connect the syringe to the stopcock, open the stopcock, just pull the air back, close the stopcock. I would recommend, unless you're a stopcock expert, that you actually take the syringe off and blow the air out. Many years ago, when I was a resident, I thought I saw a paper on this. I thought, let me give this a try. So I turned the stopcock, pulled the air out, did this, got rid of the air, did this, got rid of the air, pushed it back in, and I was opening the stopcock and I was loading this guy's chest wall with air. Did a repeat chest x-ray. This guy had this pneumo, like you would not believe. I'm going to put a chest tube in. Absolutely humiliated, but I learned my lesson. That's where you go, right? Nickel-victor line, second intercostal space, sterile technique, obviously. All right, so here are your results. Pretty clear, right? Half the time, 2 days, 2.5 days, needle aspirate, 4.5 days chest tube, average admission times. And complications, I mean, I think this is really, really rare. I don't know that I've seen that, but just to know that you stick something in someone's lung cavity, they can get infected, and this particular patient died. So that's not a good complication. So how about the aspiration group? 50% of them got better, and at 6 hours were fine. So that means half of them had reaccumulated. So they were allowed to go in with the needle, suck the air out again. Another half of them reaccumulated, another half were fine. So you're going to get 75% of your patients by needle aspirating, which is pretty good. And it's a pretty simple procedure. So take home. I think needle aspiration should be the first line therapy. Questions on that? Everyone's tired. Questions?
I put the pigtail last week and I was bubbles this ceiling. I felt the lung coming out of up against. I felt of that, like big film.
Okay. Yeah, I mean, I know there's some places where they'll send people right to IR, and they'll put this, some sort of one-way valve, like a Heimlich valve, and they'll send people out. Okay. All right, I think this is the last one. I will take me to, yeah, I got the orange light. We'll finish up with this one. This is a cautionary tale. It's got really nothing to do with dexamethasone. It's got to do with using the literature appropriately. How many people here give steroids to their people with sore throats? Quite a few. Okay, it works. It's not terrible. So this study was looking at the effects of one dose of 10 milligrams of oral dexamethasone. It's a bizarre study. It's from England. And I'll tell you why it's bizarre, not because it's from England. It's in patients not deemed to require immediate antibiotics. That kind of got me a little puzzled because I actually don't use antibiotics in strep at all. And maybe I should have included the studies to show why I don't do that. But I think those are like 20 years old, so I assumed everyone already knew that. But at any rate, if you're going to give antibiotics to someone with strep, you want to give it to them right away. And it's got to be within the first 24 hours, because really all you're getting is maybe 10, 15 hours of relief sooner. And if you don't give it, then that's all you're getting. So if you wait 2 or 3 days and then tell someone it still hurts, take penicillin, it's ludicrous. But that's not the story. So 576 adults in England. I don't think they were offered citizenship in the U.S., and they probably wouldn't have taken it. But acute sore throat, not deemed to require immediate antibiotics, single dose of Dex, and they got the script, okay? And then they looked at, this is a really weird result, complete resolution in 24 to 48 hours. I don't know, anybody who has a sore throat gets better completely in a day, regardless of what you do to them. So it was weird. But here's what they found. In 48 hours, they concluded significantly more complete resolution if you got dexamethasone. So what does that mean? You give someone Dex, they did a number needed to treat, every 12 patients you treated, in 48 hours and 2 days, they're completely better if they got the dexamethasone. Okay? And there's no difference in over-the-counter analgesic use, culture results, ultimate use of antibiotics, time lost for none of that stuff. All right? So they say take home 10 milligrams of Dex, it's superior pain relief. Okay, that's great. So if you're someone who likes to take a paper, look at the abstract page, and read this, I would walk away from that saying, that's great. I'm going to use this. I might as well. It's just a single dose. It'll be better in a couple of days. Why not? So if you look at the results of the study, the 24-hour group, there were 5% of the Dex group had complete resolution. We did a p-value, which is another story altogether. P-values are not really that helpful. It was non-significant. So when they go to 48 hours, 6% had complete resolution, and now their p-value is significant, and now they say significantly increased the relief. We're talking going from 5 to 6%. So it's just, this is a nice little tiny cautionary tale about how you consume literature. And I don't know if any of you were here last year, we sort of went through the TPA literature and how that was kind of, messed with. So you gotta be very careful. So if you're someone that doesn't read literature, that's cool. Just find someone you trust who does, either a blog or one of these things, and make sure they've gone through your papers before you take things at face value. And part 2 coming tomorrow.